Thank you, sir. I apologize, but I guess we're starting a bit before time. Okay, I'll be speaking on the management of femoral head fractures. Now, femoral head fractures are caused by significant force, often as a complication of 5 to 15% dislocation of hip. They often go undiagnosed, and quick and accurate assessment of the severity of injury is required to institute proper treatment. The most common causes of femoral head fractures are naturally motor vehicular accidents. Other causes include fall from heights, industrial accidents, and sports injuries in rare cases, especially if it's contact sports like rugby or American football. Now, the fracture generally occurs when an axial load is applied while the hip is flexed and internally rotated. We're all familiar with the fact that posterior dislocations can result into a fracture of the posterior wall of the acetabulum, the fracture of the femoral head, and in cases, cartilaginous and ligamentous injuries. Now, the position of the hip at the time when the impact actually happens determines whether the injury pattern will be a purely dislocation or a fracture dislocation. With greater amounts of flexion at the time of impact usually results into a pure dislocation scenario. However, with lesser amount of flexion, we end up with a fracture dislocation. And the lesser degrees of flexion also result into a femoral head fracture being of a larger size. The fracture occurs by the shear as the femoral head hits the rim of the acetabulum and then the head dislocates. Now, we're all familiar with the vascular supply of the femoral head. The interesting parts to keep in mind are that fractures that result into an injury of the intercapsular plexus are more likely to result into an AVN of the femoral head than those fractures that cause avulsion of the ligamento teres. Now, these patients are associated with high percentage of associated injuries. Therefore, it is mandatory that we do a complete trauma evaluation to rule out other injuries in the body. Associated orthopedic injuries include contusion of the distal femur, patellar fractures, and foot fractures in rare cases when the knee is extended at the time of impact, as is the case when you have road traffic accidents and dashboard injuries. Now, sciatic nerve injuries occur in 10% of adult and 5% of pediatric hip dislocations. The stretching and contusion are the most common varieties, though in rare cases, piercing and transection of the nerve by a sharp bony piece can occur. But what is most encouraging as far as the treatment is concerned, that most commonly these resolve with the reduction of hip and the passage of time. Now, naturally, radiology will form the cornerstone of your diagnosis. In addition to the conventionally done AP, pelvic view, and lateral view of the affected side, it is recommended that you do a Judith inlet and outlet views. Another important point to be considered is the fact that all these 4 views should be repeated after your reduction has been achieved. Now, what will this radiology tell us? Well, first, it will show us the direction of dislocation. An assessment on the size of the femoral head with respect to the contralateral side should tell you whether it is an anterior dislocation, in which case the head appears to be a bit larger, or a posterior dislocation when the head appears to be smaller. Now, radiology will usually provide enough information for you to proceed with reduction maneuvers. However, it is inadequate to rule out femoral head fractures, especially small femoral head fractures, since these can be obscured by overlying structures. So naturally, the main thrust of your diagnosis will be based on the CT scan. And that is why the CT scan is termed to be the gold standard. The CT scan will reveal non-displaced fractures, the congruity of the reduction that you have been able to achieve, the presence of any intra-articular free fragments, what is the size of these bony fragments, and associated head, neck, and acetabular fractures. Some surgeons also recommend MRI, though it has to be kept in mind that it is not shown to be of any benefit in acute evaluation and treatment, though it will reveal labral tears and soft tissue anatomy, both that do not contribute to your treatment. Now, primarily, the femoral head fractures are of two varieties. The compression variety, which is analogous to a Hill-6 injury, which results from the impact of the femoral head on the rim of the acetabulum, and the avulsion or sharing variety, which is typically an oblique fracture which runs through the femoral head. These are often displaced and often anteromedial. Now, in addition to the AO classification, the most commonly used classification is the Pipkin's classification, which is based on the relationship of the fracture line with respect to the fovea centralis, and it's associated with head and neck fractures. Now, Pipkin's classification has prognostic value. Various studies have shown that type 1 and 2 fractures have better outcomes clinically as compared to type 3 and 4 fractures, though there are certain amounts of debate as to which has a better prognosis between type 3 and type 4. Now, let's briefly discuss these types. Pipkin's type 1 is a fracture that does not involve the weight-bearing dome. And we can proceed with conservative treatment in type 1 fractures if the fracture is infrafoveal and you have been anatomically achieving the reduction with less than 2 mm of displacement, there is presence of no intra-articular free fragments, and post-reduction, your hip joint is stable. If you decide to proceed with conservative treatment, limit the patient's adduction and internal rotation for about 4 to 6 weeks. However, if any of these criteria are not met, it is mandatory that you go in for surgical intervention, of which there are 2 varieties that you can do. The recommended would be you try and reduce the fracture and stabilize it. However, in a high percentage of cases, due to comminution and small bony fragments, this may not be possible, and therefore, do not leave it as such for those pieces to act as free floating fragments. Instead, excise these fragments. Now, this is a patient, a 21-year-old male, who has a road traffic accident, a motorbike accident, and sustains bilateral hip injury. Both the fractures are reduced, and the fracture fragments are found to be within the zones of acceptance. A follow-up at 1 year shows that both the fractures have united, and it is assumed that it is a good result. However, the patient presents at 3 years with complaints of bilateral hip pain and restriction of movement, and it is found that there is development of bilateral AVN and consequently a poor result. So these patients have to be followed for a certain longer period of time. Now, this is a 32-year-old male car crash victim who has a posterior superior dislocation with a type 1 Pipkin's. CT 3D reconstruction shows that there is extensive comminution and the fracture fragments are relatively small and do not fit the criteria for fixation, and therefore these fracture fragments are removed. Now, type 2 fractures are those in which the fracture line extends above the fovea centralis, that is to say, it involves the weight-bearing dome. Non-operative treatment should only be considered if after hip reduction the fracture fragments are anatomically reduced, and therefore the indication of surgery would naturally be an unsuccessful closed reduction with more than 1 mm of step-off, or any residual instability post your reduction, or the presence of any free fragments inside the joint, and importantly, a case if sciatic nerve deficit has occurred which was not present prior to reduction. Here the point I would like to make is less than 2 mm of displacement is acceptable for type 1 fractures, but for type 2 fractures it would be less than 1 mm because this is the weight-bearing portion. Now, type 2 fractures can be approached either by a posterior approach or an anterior approach. Most of the surgeons tend to use an approach that they have been trained with and they are doing it on a regular basis and are comfortable with. But certain points should be kept in mind. The incidence of an AVN following surgery is found to be higher with a posterior approach. And this is presumed to be the fact because the medial circumflex artery anastomoses posteriorly and could be iatrogenically damaged. Anterior approach, in addition to having lower incidence of AVN, is also preferred since it is easier to approach and fix these fragments, for majority of these fragments are anteromedial. Now, fixation should be done with a minimum of screws, which could be 2.7 or 3.5 mm configuration. If you're using canceller screws, always countersink in the head to avoid screw head prominences. Headless compression screws are preferred, though a number of studies have shown that they have less stable fixation as compared to canceller screws. And nowadays, bioabsorbable screws are also available, but personally, I have no experience with them. Now, the fixation in type 2 fractures gives unpredictable outcome results. But however, it is still recommended that you reconstruct the head whenever possible, for anatomic reduction seems to be the most important factor in determining outcome quality. And also because excision of large fragments, which is invariably the case scenario in type 2 fractures, will create instability and hence is contraindicated. This is a type 2 fracture which was approached through a posterior approach after a flip osteotomy and fixed with 3 canceller screws. Now, this is a patient who presents to us 3 months post hip dislocation with complaints of pain, restricted motion, and activity limitation. There is a malunited femoral head fracture, which is then put into the right place and fixed with 2 Herbert screws after a posterior approach, which is along with a flip osteotomy. Follow-up at 1 year shows that the fracture has united. There are no AVN changes, though 1 year is still early, and the joint line is well maintained with no limitation of motions. A 40-year-old male who presents to us with a transverse type 2 fracture. Such scenarios are often irreducible, and which was the case with this scenario. Closed reduction could not be achieved. Therefore, through an anterolateral approach, the femoral head fracture was removed, the acetabulum inspected for free fragments, and then the head atraumatically dislocated anteriorly, and the fracture fixed under direct visualization with 3 full-threaded canceller screws, which were countersunk. Now, often you come across scenarios where you have subchondral depressions associated with femoral head fractures. And unless you are a person who's doing the osteobiologics, like Dr. Shantaram Shetty said today, you're left with a sort of a scenario as to how to tackle these subchondral depressions. Now, this was a case that I observed, and this is not my case, during one of my earlier fellowships with Dr. Mark Esser in Melbourne. And what they do is that in addition to fixing the femoral head fracture, they replace the subchondral depression with what they call a hemicap. Now, the rationale is if less than 1/3 of the circumference of the femoral head is involved, then it can be replaced, the subchondral depression can be replaced with a hemicap. It acts as a partial surface replacement. This hemicap comes in all shapes and sizes. So the application of a hemicap along with fixation of the femoral head after a posterior approach with a fixed trochanteric flip osteotomy. So what are the consequences? No significant change in type 1, so they can be excised. But in type 2, it shifts the load-bearing patterns and reduces the joint contract area, increases the pressure on the cartilage, so avoid excision of these fragments and always try and preserve it. Type 3 fractures are fractures which may be type 1 or 2 with an associated neck fracture. These have high incidences of AVN and degeneration with displaced fractures are an indication for hemiarthroplasty in the elderly, but attempts at open reduction internal fixation should be done in young active patients. Type 3 fractures, treatment would depend on whether the neck is unreduced or undisplaced or displaced. If it is undisplaced, make sure you stabilize the neck before your attempted reduction. And if it is displaced, naturally closed reduction would be futile. In the elderly, proceed with hemi replacement, and in the young, do an open reduction of the hip and then stabilize the neck and the head fractures. Now, certain scenarios where you have irreducible femoral head fractures. This most commonly occurs if there is a sagittal plane fracture of the femoral head, 10% cases. The treatment protocol would be try and identify it on the basis of the sagittal plane fracture. Do not attempt closed reduction, and do an open reduction and fixation through an anterior approach. You may be faced with a scenario where you have displaced, your reduction maneuver had displaced a previously undisplaced neck. Don't worry, assume it as if it was a displaced fracture to start with. Type 4 fractures are those which are an associated acetabular fracture. Now, these require appropriate treatment for femoral head and acetabular fractures, since these are associated with high incidences of AVN and post-traumatic osteoarthritis. It is, how, in contrast to the type 2 fractures, often it is more easy to fix these through a posterior approach and along with a trochanteric flip osteotomy, which gives good visualization, good fixation, and the chance to fix the posterior wall fracture at the same time. This is a patient, 55-year-old male with bilateral pelvic injury. Our right side had a Pipkin's type 4. The femoral head was fixed and the small posterior wall was fixed with a single canceller screw. 2 years, relatively good results. A 55-year-old motorbike accident, closed reduction futile. Through an anterior approach, same procedure, remove it, anteriorly dislocate it, fix it under direct visualization, and this is the fixation follow-up at 1 year. Now, often you are faced with scenarios when posterior walls also have extensive comminution. In this case, through a posterior approach coupled with a trochanteric flip osteotomy, the femoral head is fixed with Herbert screws and the posterior wall is fixed with a reconstruction plate. Now, rehabilitation is important. We have to try and start immediate range of motion exercises and make sure we keep the patient on good strengthening protocols as far as the quadriceps and abductors are concerned, but delay the weight bearing till we seek consolidated union radiologically confirmed. Complications that you may encounter include heterotropic ossification, which is more with an anterior approach, AVNs, sciatic nerve neuropraxia, but in 60 to 70% of cases, there is spontaneous recovery and decreased internal rotation. In fact, the decreased internal rotation would be the commonest complication that you would encounter. The results are quite encouraging for type 1 and 2 fractures. In fact, studies have shown that you get good results in 75% of cases in type 1 and type 2. But the results in type 3 and type 4 are unpredictable. And the major influencing factor would be the time elapsed from injury to your treatment and the sort of anatomical reduction that you have been able to achieve. So the take-home message would be, these are commonly missed with potentially devastating consequences. These should be ruled out in every patient of posterior dislocation of hip. Morbidity increases as we go from type 1 to type 4s. An appropriate classification allows for a rapid triage and institution of proper management protocols. And if properly treated, results are encouraging, but most importantly, when you treat these patients, always give a guarded prognosis and keep them informed at the sort of complications of AVN that can occur. For if you have done that, you would relatively have even if the patient goes into an AVN, you would have a satisfied patient, but if you haven't done that, the patient might blame you for the complications that occur at a later stage. Thank you for your attention.